All right, so we left off here last week because I wanted to make sure we had plenty of time to talk about the neurocognitive disorders. And so this is sort of a reframe they did in 2013 with DSM-5. These used to all just be sort of listed separately, but they decided to put these under an umbrella of neurocognitive disorders. So major neurocognitive disorders are what we think of when we think of dementias and things along those lines. So you have substantial decline in at least one of these areas of cognitive function. So memory and learning, attention, visual perception, planning and decision-making, language ability, and social awareness. And again, depending on which type of neurocognitive disorder it is, it could be all of these. And then those cognitive deficits interfere with their ability to live independently. Mild neurocognitive disorder, there we go, means that there's modest decline in one or more areas, and you don't have, you could still live independently, essentially. And so mild neurocognitive disorder is essentially what you can diagnose someone with when they're clearly struggling with symptoms of dementia, but they can still do basic self-care needs. Because what happens as you get into the later stages of things like Alzheimer's or other dementias is you can't even use the restroom by yourself. So obviously then you can't live independently. So this was controversial because people were kind of worried that this could be over-pathologized and that the mild neurocognitive disorder could be misdiagnosed as people we all just forget stuff as we this made me really depressed when I first learned it. So hopefully it doesn't do the same to y'all, but your brain keeps developing until you're about 25. And in fact, the prefrontal cortex is what's still developing, which is why teenagers don't have great inhibition and things like that. And then as soon as you hit that, you start cognitive decline. So I was in grad school when I found that out. So I was around 25 and I was oh man. Obviously it's not severe, but everybody goes through it. So some people worry that it could be overdiagnosed, overpathologized. So Alzheimer's, I think, is the most common version that we think of when we think of neurocognitive disorder. So the way this is framed now is that what we're diagnosing as psychologists or psychiatrists is the neurocognitive disorder due to the medical disease. So a medical doctor would most likely be diagnosing something like Alzheimer's, but what we're looking at and what we're trying to help with is all of the cognitive things going on with that. So in order to get this diagnosis, you have to meet criteria for major or mild neurocognitive disorder. With Alzheimer's in particular, memory is an early and prominent feature that they start to lose their memory. And you also have to make sure that it's not due to them having a stroke or some other things that can cause neurocognitive disorders or other medical issues. Alzheimer's is pretty insidious. It can be really hard to parse it apart from normal cognitive decline, particularly at the beginning. And then it's 8 to 10 years before people pass away. But some may live 20 years with it. And what's really sad is late stage Alzheimer's, a lot of times you just don't recognize people you've known your whole life. Again, you can't really take care of basic functions. And it often begins with, again, what looks like normal aging, mild memory problem, lapses of attention, and difficulties in communication. Delirium is something we need to be aware of, particularly in older adults as well, although people of any age can get it. And delirium is temporary, and it's a disturbance in attention and orientation to the environment. Essentially, you don't know where you are, you have a hard time focusing on what other people are saying to you. It develops over a short period of time. It represents an acute, so in the moment change. And there's a change in at least one cognitive domain. So this is really common with like high fevers, for older adults in particular, if they get urinary tract infections, this is fairly common. And you want to, if you're working as a psychologist or a medical doctor, and someone comes in with this, you want to screen them for that stuff, right? Because if it is something like an UTI or some other type of bacteria, virus that's causing the fever, what you want to do is treat that, right? Get those symptoms down. If you don't, what can happen is that's drawn out, right? So that it just continually, it's like having a high fever for a long time isn't good, right? Having symptoms of any of these types of things that are treatable isn't really great. So essentially, it can lead to permanent problems if you don't treat it. So this is something that we always want to be aware of when we're working with older adults, that we're not just assuming they have a neurocognitive disorder when it might be this. There are a whole host of other diseases that can cause neurocognitive disorder. So vascular follows some sort of stroke. And so with what's really interesting is, so with Alzheimer's, we tend to see like a general decline, like if this was the graph of functioning, right, it would just kind of go down over time. For vascular dementia, it's like they're doing fine, and then they have the stroke and functioning goes down immediately. Or what happens sometimes is people have a bunch of mini strokes. These are called TIAs. And so then it's like a step, right? They do fine for a while, they have another mini stroke, their functioning goes down. And then cognitive function may continue to be normal in the areas of the brain not affected by stroke. So like this is very particular to where the stroke happens in the brain. If it happens in centers related to memory, your memory is going to be impaired. If it happens in centers related to motor function, your motor function is going to be impaired. There could other things. So there's frontal temporal dementia or frontal temporal neurocognitive disorder. It's also called Pick's disease. This affects the frontal and temporal lobes, maybe not surprisingly given the name. It's clinically similar to Alzheimer's. This and Lewy body dementia are essentially like you get the same symptoms of Alzheimer's. It's just the pathology, what causes it is slightly different. So with Alzheimer's, it's like your axons get tangled up. They call those neurofibrillary tangles, and then gunk builds up in the brain. In these, it would be like a different type of gunk, if that makes sense. Creutzfeldt-Jakob disease, we call neurocognitive disorder due to prion disease. It's caused by a very slow acting virus. And it can cause, in addition to the symptoms of neurocognitive disorder, spasms throughout the body. Some of the things that we think of again as more medical can affect and cause neurocognitive disorders. So Huntington's is genetic. We know the clear genetic component to it. So memory problems worsen over time, along with personality changes, mood difficulties, and movement problems. So Huntington's is sometimes called Huntington's chorea, and that the word chorea sort of translates to dance, because their movements will be like really fluid and almost sinuous in their trunk and their limbs. And then Parkinson's disease is a slow progressive neurological disorder with tremors, what they call cogwheel rigidity, where like instead of smoothly going through motions, you might kind of jerk between them, and unsteadiness. They tend to be very far forward, and so it's like they can kind of stumble over their own feet. And so this is what the actor Michael J. Fox has. Anger in older adults. This is certainly something that people can have difficulties managing. And sometimes they have like really justifiable reasons to be angry, right? So if they're in physical pain, they're not getting the care they need for that or for other things, right? They have communication issues. This is actually one of my like biggest fears, is to be essentially like generally with it, but not able to communicate that to people, right? Like that sounds really scary to me. Just being frustrated, having emotional issues, Not getting rest. So if you're used to having, your very quiet individual bedroom, and now you've moved into an assisted care facility and something is always beeping and someone's always walking by, right? That can really change your sleeping patterns. Dementia and or stroke. Sometimes they just get bored. I mean, Jasmine's not here today, but I know she shared like that sometimes when she goes in to see people, that's the only real like interaction they have with someone all day long, which is really sad, right? Power conflicts, particularly as people who have been very independent all their life need to shift to letting someone else take care of them. That can be really hard, right? And fatigue and even hunger, right? And sometimes hunger is just nothing sounds good to them. Sometimes it's due to dental issues, right? If they don't have the right dentures, things along those lines. And so in terms of how to manage that, you want to communicate before a problem escalates, focus on the issue. I think the knee-jerk reaction in a lot is like, oh, this person is impossible, right? But thinking instead about what's causing them to feel impossible to you. Mindfulness and deep breathing, which again, we're going to go over next week, can help anybody of any age. Increasing activity level. So I know a lot of assisted care facilities will bring in people to do chair yoga or silver sneakers, which are little like older folks aerobics classes, or even just basic things like volleyball with balloons and things like that. And then having talk therapy, not only for the older adult, but also for their caregiver, right? Because that can be really stressful. And in particular, I don't know if you all have heard the term sandwich generation. So sort of like boomers, Gen X, millennials, probably all will be stuck with it too, are called the sandwich generation because it's like they have to take care of their aging parents and their own kids, right? Sometimes at the same time. All right, so TBI, or traumatic brain injury. This is caused by any kind of bump, blow, or jolt to the head. Now, I think a really common misconception for folks who don't understand TBI is that everyone thinks it has to be like you actually hit something, right? Like NFL players, their helmets running together, things like that. But in fact, it can be secondary. So for example, people might get a TBI in a car accident if the seatbelt stops them so short that their head kind of goes forward. And what happens is your brain is kind of like jello and it can like hit the front of your skull, hit the back of your skull. Neurons can kind of turn and rip. It's not pretty, right? Or what we saw from a lot of folks who came back from Iraq and Afghanistan, OEF, OIF, was concussive blasts. So when the roadside explosive devices go off, they might not have been hit by something, but just the force of the blast essentially going through your body caused a lot of mild TBIs for them, or what we sometimes just call concussions. You can also have the penetrating ones. These are open head injuries. So these are where something actually enters the skull, goes through the brain tissue. So this is Phineas Gage with his railroad iron going through his brain. This is Representative Gabby Giffords, who had the bullet go through her brain, right? It can be shrapnel, any kind of bone fragment, a knife, things along those lines. But the ones we hear about most often are the closed head or non-penetrating TBIs. And this is where, again, there's some sort of external force strong enough to move the brain within the skull. And so, as I mentioned, this is sort of, unfortunately, the signature injury of Iraq and Afghanistan wars. A lot of young veterans came back with closed head injuries. And it's like, you might not even realize in the moment anything was wrong, right? But later on, they're getting migraines, they're getting tinnitus, which is where you have like ringing in your ears, you're having memory problems, things along those lines. And so falls, if you hit your head, car accidents, sports injuries, again, is the one we really think of, particularly the NFL, right? But also more and more evidence suggesting soccer from headers, that there might be some of this sort of accumulated effect as well. Blast injuries, as I mentioned, being struck by objects. In terms of the sports injuries, people have just been like, oh, we'll wear bigger helmets. And the guy that the movie Concussion is about, that Will Smith plays in the movie Concussion. I saw him on a news program once, and he had two basically like mason jars simulating the brain moving around in the skull, you know, the jello brain. And he wrapped one in a lot of bubble to like simulate a good helmet. And then he showed like when he hit it, the brain still bounces around, right? Like it doesn't help that much. Yeah, so there's a reason I don't watch the NFL anymore. And this is actually, there are several. This is the big one for me. Also, you know, the whole domestic violence thing. And then mild TBI is what we call a concussion. And so obviously repeated concussions can build up as well. Whoa, I made this way too small. Apologies. I'll read everything. I should have made this a couple slides. Okay, so some of the physical symptoms, headaches. If it's really bad, it can be seizures or convulsions, blurred or double vision, the pupils dilating differently. Clear fluids draining from the nose or ears, nausea and vomiting. And then something that they haven't had before that's neurologic, like slurred speech, weakness of arms, leg, or face, or loss of balance. I would say that like the really obvious ones are less frequent, or at least they last less long. And what we really see are these cognitive behavioral and perception sensation ones. So in terms of cognitive behavioral, sometimes at the time of injury, we'll see a loss of consciousness. And even if you black out for just a couple seconds, that can have consequences. Or just like it's hard to awaken them. It can have confusion or disorientation. I mean, it's certainly not what we think of when we think of sitcom getting bonked on the head, right? And then at the end of the episode, you get bonked on the head again and you remember everything, but it's going to affect your memory and your orientation. Problems remembering, concentrating, making decisions. It can really mess with your sleep, either cause hypersomnia, sleeping more, or insomnia, difficulty falling or staying asleep, or it's hard to wake them up. And frustration and irritability. And I wonder how much of that is just from dealing with all the other symptoms, just like we talked about with the older adults, right? In terms of perception and sensation, getting lightheaded, dizzy, sense of vertigo, difficulty with balance or coordination, blurred vision, hearing problems, as I mentioned, tinnitus, that ringing in the ears, having weird tastes in their mouth, like a metallic taste, sensitivity to light or sound. So when I was at the VA, I worked on a multidisciplinary team. It was a neurologist, me, a social worker, and a neurological nurse. And we would all evaluate them together. Really cool. And very, very common to have sensitivity to light or sound, where these folks would talk about like days that they would need to just be in a room with all the lights off, curtains drawn, things like that. Mood changes or swings, agitation, combativeness, or other unusual behavior, feeling anxious or depressed, and then that fatigue or drowsiness. Yeah.
So why is it you get a concussion, you're not supposed to like fall asleep?
It's a good question. And so from what I understand, like that's not always true.
Okay.
But I think that what can happen is you can miss symptoms, and that's the biggest thing. Is like, so there is, I'm gonna forget his name. But there's this great comedian, Drew Lynch, and he got a concussion. He was in like a work softball game, and it actually turned out he got hit in the throat with a ball, and then fell and hit his head. And he was just like, I feel fine, whatever. Went about his day, went to sleep, and woke up and actually like found out he had a lot of like airway problems and things like that. So I think that's a big part of it, is monitoring those symptoms and things along those lines. Right. Yeah, I remember a friend of mine, she played lacrosse and getting beaten on the back of the head in college and having to sit with her and keep her awake. Yeah. And I think that's the reason why, although there might be other medical reasons I'm not quite sure about. But yeah, definitely. In terms of consciousness, sometimes we'll see this minimally conscious state where they have awareness or some awareness, but it's hard for them to interact with folks around them. And this we often see like right after the TBI where people are just sort of like, what are you talking to me? Like, what? Right. If it's severe enough, we can see some of these other ones. So vegetative state is where they're unconscious, unaware of their surroundings. Sometimes they have unresponsive alertness. And then they can end up in a persistent vegetative state, sorry. And then coma, they're unconscious, unaware, unable to respond to any kind of external stimuli, like when they flash light on your eyes or they try to like prick your finger or your toes. And then what can happen if you have very severe brain injury is that essentially you, even if your body can be kept alive with life support, your brain is no longer functioning essentially. And that's obviously where you need to make tough decisions as a family, and having things like DNRs or clearly spelled out medical agreements can be really important. Okay, so in terms of the type of injury, this diffuse axonal injury is what I was talking about when I talked about how axons can like turn and twist and rip. And so rotational forces or sudden forceful stopping. And like I said, because the brain kind of bounces around, let's say you hit the front of your head, you also typically have some stuff going on at the back of your head, or vice versa. You fall on the back of your head, you also probably have some stuff on the front of your brain. Hematomas are bleeding in and around the brain, caused by a rupture to a blood vessel. And again, this can come from either a closed head or an open head injury. Contusions are bruising or swelling of the brain. It's going to happen when essentially your capillaries in the brain bleed into brain tissue. When this gets severe, sometimes what they'll have to do is go in and take off a part of your skull, so that you don't have additional injury from the skull or the brain, like pressing on the skull as it swells. And then skull fractures are breaks and cracks in the skull itself. And so obviously these can take a while to heal because it's not like you can just like put your whole head in a cast and call it a day, right? So we have to be really careful about these things. And then I wanted to talk about CTE. Actually, I think Buchan requested this, but I just think it's an important thing to talk about. So this is from repeated head trauma, even mild, even those NTBIs or concussions. So repeated TBIs, repeated hits to the head. And this is what, again, I wish I remembered his name, but the main character in the movie Concussion discovered, essentially. And because this is known now, this is why, unfortunately, you'll see NFL players die by suicide, and they shoot themselves in the heart instead of the head because they want people to look at their brain and study the effects of CTE. So as of right now, it can only be definitively diagnosed after death because you have to do autopsy. So this is the normal brain, and then this is a brain with advanced CTE. So you can see the loss of matter. Obviously, when you have a loss of brain matter, shrinkage, things like that, it's going to negatively affect you. So the symptoms here, and this is where this becomes really problematic for folks with their families. So not only their spouses, but if they have kids, right? They're having impulse control problems and aggression, mood swings, depression, paranoia, anxiety, and then those thoughts of death by suicide. And most who have CTE eventually experience essentially a neurocognitive disorder, including problems with executive functioning, which is sequencing, ordering, organizing things. So that's what helps you know how to sequence and plan your day. It's what helps you know something as simple as I need to put my sock on before my shoe and not the other way around, right? Impaired judgment, which again, if you're pairing that with impulse control problems, you can imagine how people would start self-medicating with drugs, alcohol, engage in other dangerous behaviors like drinking and driving. Short-term memory issues, dementia and confusion. And then I thought this was really interesting, that they're starting to see problems with sleep. And in particularly, it seems like their rapid eye movement sleep, which is when you dream, and it seems to be the sleep that's like most important and beneficial for resting and recuperating our brains, like babies have a lot more REM sleep, for example. That's related to CTE, like having a disruption in that. And then sometimes they've just got other sleep disorders like sleep apnea and get them a CPAP and that'll help with some of this stuff, right? So the most common causes, not surprisingly, are these contact sports, boxing, martial arts, football here, they're referring to soccer, rugby, and American football. Actually, I don't know if anyone's ever played rugby or watched rugby. Like in some ways, I think it's worse than American football because they wear a lot less protective gear. Again, in the military, having blast injuries, and in fact, I know that at least a few years back, the NFL had put sensors in the helmets to like measure strengths of blows, and they were using some of that research to also try to help veterans who had had these. And then the one we don't think about are people who have repeated head injuries and repeated mild TBIs due to domestic violence, right? So if you're constantly being hit in the head as part of your abuse, that can also happen. Alrighty, so now I have some of the stuff that people just always want to know about, even if they're not going to run into it. So we'll talk about psychosis a little bit. So this is a state of being profoundly out of touch with reality. And symptoms here are hallucinations, which are experiencing something that's not there through any of your senses. So seeing, hearing, smelling, tasting, touching, something that's not there. And then delusions, which are fixed false beliefs. These, and sometimes they have awareness that they know these beliefs don't make sense, but they still like don't let them go. So schizophrenia is a specific type of psychosis. The best way to think about how to explain this is that you could think of psychosis like a fever, and multiple things can cause a fever, right? If you have a fever, it doesn't mean for sure you have COVID. Just like if you have delusions or hallucinations, it doesn't mean for sure you have schizophrenia. So again, psychosis is a broad term, and then schizophrenia is a very specific type of psychosis that also has disturbed thought, language, and behavior. Other things that can cause psychosis include medical conditions, so something like delirium can cause you to hallucinate occasionally, but also drug, alcohol, things along those lines. All right, so in terms of the symptoms, they talk about positive and negative symptoms. Positive doesn't mean it's good to have them. They just mean it's something that a typical person doesn't have. So positive here means like additive. So pathological excesses, exaggerations, or distortions from normal functioning. So something like hallucinations or delusions would be a quote unquote positive symptom because it's something over and above what the average person experiences. Also things like disordered speech, thought, and behavior. And then the negative symptoms represent pathological deficits. And so some of these can look like depression, basically. So flat affect, having a loss of motivation. But in schizophrenia, it can get so severe that occasionally the folks just cannot talk. So these are the criteria. I'm going to go just throw them all up. There we go. So they have to have it for at least a month. And there is, very similar to acute stress disorder and PTSD, there is a diagnosis you can give someone up to a month if they start showing these symptoms. So they have to have delusion. They have to have 2 of these A through E. Delusions, hallucinations, disorganized speech comes in a whole host of ways, repeating what other people say, word salad, where they just sort of like say random words. Abnormal motor activity, including catatonia, which is where they may hold poses for hours on end, or just not respond. And then those negative symptoms. And at least one of them has to be one of the first 3, because you can actually have these 2 just with depression, right? So we don't want to be diagnosing everyone with depression with schizophrenia. Individual functions are the individual functions less well, essentially. Particularly prior to the symptoms. And then they have at least some degree of impaired functioning for essentially 6 months. So to give you an example of 3, so the only schizophrenia patient I ever saw long-term, because it wasn't my area of specialty, and you really do need to specialize in psychosis, but her psychotic symptoms were controlled, so I was essentially treating her negative symptoms. She had been a high school art teacher, living on her own, functioning relatively independently, had her psychotic break at school where she thought there were helicopters circling and that the Russian mob was coming to get her. She was dating someone at the time that it's unclear whether or not he actually was in the Russian mob, so that played into it. After that, after being hospitalized, she had to quit her job, move in with her parents, and didn't even do her art anymore, which for someone that was their livelihood, really tough, right? So essentially treating her was like treating someone with very severe depression. So schizoaffective disorder is one of the things you can diagnose people with if they're having a mood episode and a psychotic episode at the same time. Basically, if they onset at the same time, you can diagnose them as schizoaffective rather than giving them 2 diagnoses, if that makes sense. Brief psychotic disorder is what you can diagnose them with that first month. The reason this is parsed out differently is there are people that have very brief psychotic episodes and are never going to have one again, right? So we don't want to diagnose those people with schizophrenia if it's going to be a one-off. They return to the level of functioning that existed prior to the symptoms, or if it goes beyond a month, then we're looking at a different diagnosis. Schizophreniform disorder is what we can diagnose someone with if they haven't quite hit that 6 months of changed functioning in schizophrenia. And again, this is just in recognition that sometimes people have this for a few months, right? And again, trying not to over-pathologize. And then you can have a disorder where your main symptom is delusions. And you don't have any of the other symptoms. You're not having the odd or bizarre speech or behavior, but you have delusions you truly believe, right? So some of the thought disorder symptoms we see: poverty of speech. People just don't talk as much, don't give as elaborate responses. Poverty of content of speech is where there's vagueness. Everything's really abstract, so it's hard to understand what they're actually talking about. Pressured speech we see in some other disorders as well, particularly people with type A personality, which diagnostically often ends up being obsessive compulsive personality disorder. So this is where people are like, I need to talk, let's get it out. And it's like they can get loud and it can be really hard to interrupt them, and it just feels like they're just pressurized getting it out. Distractible speech, they just like can't maintain a topic. Their attention squirrel, right? Their attention just goes everywhere. Tangentiality is where you ask them a question and their answer doesn't make any sense in the context of the question you ask them. Derailment or loose associations, difficulties maintaining that topic, but they will speak on their own. You don't have to like pull something out of them. And then incoherence or word salad is where the person will just, like, if you just listen to the intonation and like the rise and fall of their voice, it sounds like they're talking normally, but they're saying nonsense words or words that don't make sense in context. I knew someone in grad school who had worked in the prison system before she came to grad school. And she said she met someone who like had word salad and he only said like 3 words basically. But again, if you didn't listen to what he was saying, just how he was saying it, it sounded like he was having a normal conversation. Illogicality makes sense. Everything illogical. Okay, so then we get into some of the ones that are more obvious. So clanging Or these are sometimes called clang association. So they're really about rhyming rather than words making sense. Well, hell, it's well to tell, right? And you're like, what does that mean? But to them, it makes sense. Neologisms, they'll create new words. I have a head vise for headache, things along those lines. Words approximations where they'll almost get the right word, but then they are using a word in the way it doesn't actually mean it, and they might do that really consistently. Circumstantiality, they have speech is over inclusive, they're including way too many irrelevant details. You ask them to tell you a story, and what took 5 minutes to happen takes an hour for them to tell you the story. And then loss of goal, where like sort of halfway through what they're talking about, they'll forget what they're talking about and not really ever get to the point. Perseveration, Jesus. Okay. Peter Piper picked a peck of pickled peppers. Just like get the tongue going. All right, perseveration. All right. Is repetition of words, ideas, subject, they just can't get off of it. Probably the one that like ends up annoying the people around them the most is echolalia. And this is like a kid repeating after their sibling. And again, they're not trying to be annoying. It's just how they are communicating. They'll repeat what you say. Blocking is where they'll try to talk, but it's like stuff won't come out. You can tell they're trying to say something, but no sound comes out. Might have stilted speech where they're, I don't know, they sound like they're on Bridgerton, basically, but they're in the modern era. Self-reference, where they refer everything back to themselves, even if they don't have a common experience. And then they can have paraphasic errors that are phonemic and semantic, where they have word pronunciation, slips of the tongue, and using inappropriate words. All right, and then again, some other stuff people are just always interested in, and the big one for this is dissociative identity disorder. This is what used to be called multiple personality disorder. So this is disruption of identity characterized by two or more distinct personality states, or the way some people experience it as an experience of possession, that like someone else takes over, that's the second personality. They'll have recurrent gaps in the recall of everyday events, important personal information, and or traumatic events that are beyond ordinary forgetting, or in the case of traumatic events, what we would expect in something like PTSD. And the idea is those gaps occur when a different personality takes over. Significant distress or impairment, and it's not due to like, you're just taking a lot of shrooms or something, right? And so a couple other things here, somatic symptom disorders. So factitious disorders are where people intentionally produce or feign medical symptoms in themselves. These used to be called Munchausen syndrome. They will often go to extreme lengths where they'll take medication to reduce symptoms in themselves, undergo painful treatments and surgeries. And the idea is these folks somehow psychologically get reinforced by that patient role. But you can, that's what we call a fictitious disorder imposed on self. The one that really ticks me off is what used to be called Munchausen syndrome by proxy, or fictitious disorder imposed on another. So this is where you are a caregiver for someone, whether it's a kid, an adult with developmental disabilities, an older adult, and you produce the symptoms in them. You give them the poison, the medicine, what have you, and you enjoy being in that caregiver role and getting praise for your caregiving, essentially. So this is obviously child abuse or elder abuse, right? Unfortunately, like kids can go through multiple surgeries and all these different treatments. And usually the way you can definitively diagnose this is if you separate the kid from the parent or whoever the victim is from the caregiver, they get better. And it's most common among people who themselves may have had sort of the patient role as a kid. So again, that became reinforcing. They might have been abused themselves as a child. If they have some sort of grudge against the medical profession, they feel like it did them wrong, it didn't diagnose them properly. People who have medical backgrounds, but they're typically not doctors or nurse practitioners or people with the most training. It might be someone who was just like a medical aide, worked at a doctor's office as an administrative assistant, something like that. And often, not surprisingly, there's some sort of underlying personality issue. All right, so functional neurological symptom disorder is what Freud and everybody else used to call conversion disorder. And this is where essentially you get sensory or motor symptoms and they're not caused by anything physiological. They're caused by your stress, your psychosocial conflict or need. The symptoms often seem neurological, like paralysis or numbness, things along those lines, but they tend not to be related to the physiology of the body. So for example, you get something called glove anesthesia, where the person will say their entire hand is numb, but then nothing else. And if you look at the physiology of the nerves, there's like 2 different nerves that run up. So that just wouldn't happen physiologically that way, basically. They also retain their normal functions, but they don't know this. The goofiest version of this is in the movie Talladega Nights, where Will Ferrell's character thinks that he's paralyzed. And he's like, I'll take this fork and stab myself in the thigh. But he can feel it because he's not, right? But because of this, you can often sort of suggest to them very gently that they might regain function. And sometimes that will result in them regaining function. Somatic symptom disorder is where you have long-lasting physical ailments with little or no organic basis. And you have to have multiple ailments. You've got to have pain symptoms, gastrointestinal symptoms, sexual symptoms, neurological symptoms. And because these look like medical symptoms, these folks will go from doctor to doctor to doctor. Whenever a doctor suggests this might be psychological, they'll reject it and try a new doctor, right? And so it can be years before they're diagnosed or they accept the diagnosis. This disorder used to be called pain disorder. They made it a subclass of somatic symptom disorder in 2013. So this is pain associated with psychological factors. Pain is the key feature. This often comes after a legitimate accident or illness. You have an actual injury, but essentially, like long after everything is physically healed, you continue to experience high levels of pain. Unfortunately, I think that this disorder drove a lot of things like the opioid epidemic because people were sort of indulging it. And a lot of health psychologists now are trying to work on psychological things to help people with their pain so that they're not reliant on potentially addictive medications. And then there's what we used to call hypochondriasis. And we now call illness anxiety disorder, which I like more. It's a more accurate term. These are people who just everything in their body, they interpret as like something's going horribly wrong. And unfortunately, in our day and age, the internet doesn't help this, right? Like I knew one time that I only had a cold when I went to WebMD, and it was like, you literally have a cold, right? But most of the time it's like, you have cancer, right? So like things are sort of exaggerated and you can get misinformation or not full information online. It can look like somatization disorder, but they're really just anxious about having those symptoms or like overreacting to existing symptoms. So preoccupation with having or getting a serious illness. They're not having stress-induced symptoms, right? It's more like little physical things they're overreacting to. They're easily triggered about their health. They'll constantly check their body for signs of illness, and it's chronic. This is not just something they like, you know, I'm sure a lot of people had this at the start of COVID, right? I'm not, but you all should remember what it was like 3 years ago, 2 years ago, whatever it was. But it was definitely like, oh, I coughed. It's like, right? You start like over analyzing everything. This is something where it's like everything in your life, you're over analyzing like this. All right, I'm pretty sure this is the last group of symptoms I have, which is the conduct and oppositional defiant disorders. So these are disorders that you can see in kids. ODD are where kids are argumentative and defiant, angry and irritable. And where it really starts to get troubling is when they get vindictive. And so kids are gonna argue with adults, right? Like, that's not this. This is where kind of everything is a fight. They ignore adult requests and rules, purposely try to annoy people, and nothing's ever their fault. They blame everybody else around them. Conduct disorder is basically the precursor to what we call psychopathy or antisocial personality disorder. So these kids violate the basic rights of others. They may be aggressive and physically cruel, not only to people, but to animals. And this begins pretty young, 7 to 15 years of age. And so this repetitive and persistent pattern in which they violate the rights of others, and they violate age-appropriate social norms. And so they've got to have at least 3 of these symptoms: bullying others, physical fights, weapons use, cruelty to people or animals, stealing, while confronting a victim, sexual assault, fire setting, property destruction, breaking and entering, lying, stealing non-trivial items, staying out before curfews before the age of 13, running away from the home, truancy from school. And again, this is going to cause significant impairment. So it seems like there are some genetic factors, but also some sociocultural factors, maybe family conflicts, but we also know that not every family that has a conflict produces a child with conduct disorder, right? So there's probably something genetic as well. IED, intermittent explosive disorder, we can see in kids or in adults. And this is a person who has frequent impulsive, aggressive, angry outbursts towards property, animals, or people. They're out of proportion to the event. They're impulsive. They cause the person distress, and they cause problems, not surprisingly, if someone is aggressively acting out, right, at work or home. You don't diagnose it in kids under 6 just because they have tantrums, right? It just happens. People who have experienced physical and emotional abuse, particularly as a kid, are at higher risk because essentially you learn from what you see, right? And if your abuser acts in this way, you sort of learn like, well, that's what people do. Pyromania. This is because clearly remembering in my mind, one of my students who was coding things at EVMS, one of the files she was coding was a kiddo with pyromania, actually. And they would, like, in addition to buildings, they would set fire to like frogs. It was really disturbing. So they purposely set fires. So I don't know if anyone remembers a few years back, there was a big streak of arsons up on the Eastern Shore. Those people probably had pyromania. So they're setting fires more than one time. They have tension or emotional arousal. And it's like the fire setting helps them discharge it. They have a fascination with fire and its uses and its consequences. They get this relief or gratification when setting fires. It's not like we're doing this to get the insurance money for something I own, right? It's basically, again, like this discharge, and it's not better explained by something else. Kleptomania is the same thing, but instead of setting fires, you're stealing. And again, you feel like relief when you steal things. Women actually have kleptomania more often than men. Alrighty, and then in terms of personality disorders, the one that I'm going to cover is antisocial PD. This is people with psychopathy. These are your psychopaths, your sociopaths. Diagnostically, it's the same. So a pervasive pattern of disregard for and violation of the rights of others since at least age 15. Again, sometimes you see kids who have conduct disorder It goes into this, so they might have started 7, right? They don't conform to social norms in terms of lawful behaviors. They're very deceitful. They're impulsive and failure to plan ahead. Irritability and aggressive. Disregard for their safety and that of other people. Irresponsibility in terms of work, financial obligations. It's essentially like they have a really hard time understanding how their actions would negatively affect other people. Or if they see it, they don't care. That's symptom 7, lack of remorse. You have to be at least 18 to be diagnosed with this, but obviously you can be diagnosed with conduct disorder before that. And you need to make sure they're not doing this only when they're psychotic or manic. So the DSM-5 has an appendix where they have potential revisions of personality disorders. And so the revised version is going to focus more on these symptoms: difficulties with identity, empathy, intimacy, and things like hostility along those lines. And then there will be this specifier for psychopathic features, where essentially they're not anxious. Like, I think if anyone in this room was going to commit a crime, we would have anticipatory anxiety. These folks are not, which is one of the things that makes them really good criminals. But sometimes they're also attention seeking. So these are your serial killers that sort of leave calling cards and things like that. Alrighty, let me see. Yeah, we got time. Okay, substance use disorder again kind of goes this whole category we're covering right now are what are called the externalizing disorders. The vast majority of when we think of psychopathology, we think of things where people are kind of like beating themselves up emotionally: depression, anxiety, eating disorders, things along those lines. Externalizing disorders are things that can affect other people, and substance use can be one of those. And so you can abuse a whole host of different substances. So everything from alcohol, which we typically think of, to marijuana, which people are often surprised by, but yes, you can have a substance use disorder with marijuana, shrooms, prescription medications, anything along those lines. So essentially you build tolerance, you take larger and larger amounts. You want to control or reduce your use, but you can't. You'll spend a lot of time getting, using, and recovering from the substance. This will interfere with work, school, and or home. Even with your problems, you keep using. You'll stop engaging in activities because of the use. You'll use the substance in situations where it poses physical hazards, needle sharing, drinking and driving, things along those lines. Again, keeping using it even though you realize it's not good for you physically or psychologically. If you stop taking it, you get withdrawal. Tolerance is you need more and more amount to get the same effect. And then having cravings for it. So again, a little bit of a controversy that, we used to have 2 substance use disorders, which were abuse and dependence. I think this is not as much of an issue as it was. Woo, we got all the way through. All right. So next week, this will be great. We will just focus on meditation, relaxation, things along those lines to get everybody through midterms. And then, then it'll be spring break already. Woohoo. All righty. So I'll see everybody next week.